A new randomized trial is challenging how we manage malignant pleural effusions. A large multi-center study revisits a long-standing ICU debate. Should we prefer proton pump inhibitors or H2 blockers for stress ulcer prophylaxis in septic shock? And an ERS position statement reminds us that pleural effusion in hematologic malignancy is far more complex than we often assume. Welcome to This Week in Pulmonary and Critical Care Medicine, where we review the most clinically relevant new research for busy pulmonologists and intensivists. Let's start with pleural disease. Malignant pleural effusion remains one of the most common and burdensome complications of advanced cancer. Patients often present with dyspnea, requiring both diagnosis and symptom control, and the interventions we use can have major implications for hospital stay and quality of life. The TACTIC trial, recently published in the Lancet Respiratory Medicine, tested a strategy that many pleural specialists have considered for years, combining medical thoracoscopy with talc poudrage and simultaneous indwelling pleural catheter insertion. The rationale is intuitive. Medical thoracoscopy allows direct pleural inspection and biopsy, while talc poudrage provides pleurodesis. An indwelling pleural catheter, meanwhile, allows ongoing outpatient drainage if pleurodesis fails. But until now, this combined approach had only observational evidence. The investigators conducted a multi-center, randomized controlled trial across 11 UK hospitals, enrolling patients with symptomatic malignant pleural effusion undergoing thoracoscopy. Patients were randomized to one of two strategies. The first strategy was thoracoscopy plus talc poudrage plus IPC insertion. The second strategy was thoracoscopy plus talc poudrage alone. The study included 124 patients with co-primary outcomes of hospital length of stay and breathlessness over 4 weeks. The results were interesting. Adding an IPC did not reduce hospital stay. Median hospitalization was 1 day with IPC versus 2 days without, which was not statistically significant. Similarly, dyspnea scores were not significantly different between groups. However, the IPC group had a notable advantage. They required far fewer additional pleural procedures. Only 3% of patients in the combined therapy group required further intervention, compared with 34% in the standard care group. Safety profiles were similar between groups, and adverse event rates were comparable. So how should clinicians interpret this? The study suggests that combining thoracoscopy, talc poudrage, and IPC does not improve early dyspnea or shorten hospitalization, but it reduces the likelihood of needing repeat pleural procedures. That makes this strategy particularly attractive for patients whose priority is avoiding additional interventions or hospital visits. However, there is a trade-off. Many patients may end up with a catheter that stays in place for weeks or months, and some may never achieve pleurodesis, so the decision remains individualized. For some patients, especially those with limited life expectancy or high recurrence risk, the combined strategy may simplify future management, but it does not appear to fundamentally change short-term outcomes. Few ICU practices are as deeply embedded in clinical routines as stress ulcer prophylaxis. Yet despite decades of use, the optimal agent remains debated. A new multi-center study, published in Critical Care Medicine, revisits this issue by comparing proton pump inhibitors and histamine 2 receptor antagonists, specifically in patients with septic shock. Critically ill patients, particularly those with septic shock, are at increased risk for stress-related mucosal injury and upper gastrointestinal bleeding due to splanchnic hypoperfusion and impaired mucosal defenses. Acid suppressive therapy has therefore become standard prophylaxis in high-risk ICU patients. However, uncertainty persists about which agent provides the best balance of benefit and safety. To address this question, investigators conducted a large retrospective cohort study using a national U.S. hospital database spanning 220 hospitals. The final cohort included 15,102 adults with septic shock, of whom 5,492 received an H2 receptor antagonist and 9,610 received a proton pump inhibitor on the day of hospital admission. The primary outcome was the occurrence of upper gastrointestinal bleeding during hospitalization. After propensity-weighted adjustment, the results showed that PPI therapy was associated with a lower risk of gastrointestinal bleeding compared with H2 receptor antagonists. Specifically, the odds ratio for upper GI bleeding with PPIs was 0.78. In absolute terms, bleeding occurred in 3.0% of patients receiving PPIs versus 3.6% of patients receiving H2 receptor antagonists, representing a modest but statistically significant difference. Importantly, the investigators did not observe significant differences in several clinically important secondary outcomes. In-hospital mortality was similar between groups, with an odds ratio of 0.98. Rates of ventilator-associated pneumonia were also comparable, with an odds ratio of 0.93. Likewise, no significant differences were observed in Clostridioides difficile infection or hospital length of stay. These findings reinforce an emerging pattern seen across the literature. PPIs appear somewhat more effective at preventing stress-related bleeding, but this benefit rarely translates into improvements in mortality or other patient-centered outcomes. The accompanying editorial places the findings in context, noting that the absolute reduction in bleeding risk, approximately 0.6%, is relatively small, especially when compared with the overall mortality risk in septic shock. In other words, preventing a small number of bleeding events may not meaningfully change the clinical trajectory of patients with severe sepsis. For clinicians, the implication is not necessarily that PPIs should replace H2 receptor antagonists universally. Rather, these results support a more individualized approach. Patients with particularly high bleeding risk, such as those with coagulopathy or severe shock, may derive modest benefit from PPIs. But the broader principle remains unchanged. Stress ulcer prophylaxis should be applied selectively and reassessed frequently. Pleural effusions are common in oncology, but when they occur in the context of hematologic malignancy, they present a uniquely complex diagnostic challenge. A position statement published in Breathe in February 2026 provides a comprehensive overview of the mechanisms, diagnostic strategies, and management considerations for these effusions. Rather than focusing on a single intervention, the paper aims to clarify how clinicians should think about pleural effusion in diseases such as lymphoma, leukemia, and multiple myeloma. To understand the clinical approach, it helps to begin with prevalence. Pleural effusions occur in approximately 20 to 48% of patients with hematologic malignancies during the course of their illness. Among all malignant pleural effusions, about 10 to 16% are attributable to hematologic cancers, most commonly lymphoma and leukemia. At first glance, these numbers might suggest that pleural effusion in this population is simply another form of malignant pleural disease. But the underlying physiology is far more heterogeneous. The authors emphasize an important conceptual distinction between malignant pleural effusions and paramalignant effusions. In malignant pleural effusion, tumor cells directly infiltrate the pleura or spread through lymphatic or hematogenous routes. This process is seen in approximately 6 to 15% of non-Hodgkin lymphoma cases with pleural involvement. However, a large proportion of effusions in hematologic malignancy arise through indirect mechanisms. Mediastinal lymphadenopathy may obstruct lymphatic drainage. Thoracic duct obstruction can produce chylothorax. Cardiac dysfunction, renal impairment, infection, and treatment toxicity can all produce secondary effusions. Understanding these mechanisms matters because they directly influence diagnostic interpretation. For example, while cytology remains a cornerstone of pleural fluid evaluation, its sensitivity in hematologic malignancy is relatively modest, approximately 46%, considerably lower than in many solid tumor malignancies. This is where modern diagnostic approaches become important. Flow cytometry can detect clonal lymphoid populations even when cytology appears non-diagnostic, improving diagnostic yield in lymphoma and leukemia. When fluid analysis remains inconclusive, thoracoscopy with pleural biopsy provides diagnostic sensitivity exceeding 90% in suspected malignancy, allowing direct visualization and targeted sampling of pleural lesions. Another often overlooked feature is the biochemical profile of these effusions. Most effusions, roughly 80 to 88%, are exudates by Light's criteria, while chylous effusions account for approximately 12 to 20%. Yet appearances can be misleading. Up to 20% of chylous effusions are not visibly milky, meaning that triglyceride testing is essential even when the fluid appears serous. Perhaps the most clinically important insight is that pleural effusion in hematologic malignancy often signals disease progression or systemic complications. Its presence frequently reflects advanced disease burden and is associated with poorer prognosis. From a clinical perspective, the message is clear. Diagnosing pleural effusion in hematologic malignancy requires a multimodal approach, integrating imaging, fluid analysis, immunophenotyping, and, when necessary, thoracoscopic biopsy. Equally important, these cases benefit from close collaboration between pulmonology, hematology, pathology, and radiology. Understanding the physiology behind the effusion, not simply labeling it as malignant, is what ultimately guides effective management. 3 take-home messages from this week's literature. First, the TACTIC trial suggests that combining thoracoscopy, talc poudrage, and an indwelling pleural catheter does not improve early outcomes in malignant pleural effusion, but it reduces the need for repeat procedures. Second, in septic shock, PPI modestly reduce upper GI bleeding compared with H2 blockers, but the clinical impact appears small and prophylaxis should remain selective. And third, pleural effusion in hematologic malignancy is common, heterogeneous, and diagnostically complex, often requiring advanced testing such as flow cytometry or thoracoscopy. As always, the goal is not simply to read the literature, but to translate it into better decisions at the bedside. Thank you for listening to This Week in Pulmonary and Critical Care Medicine.